All right, why don't we go ahead and get going? We got 20 people on. That's great. So we got, I think, 8 interesting cases to kind of go over this morning. And I guess you guys have had a chance to take a look at them. Here we go right here. So somebody want to start us off here?
Yeah, that would be me. Okay. So we have a punch here. And then it looks, I'm going to go with like an inflammatory process.
Good.
I would say superficial, a little bit deeper though too.
Okay.
So I'm calling superficial and deep. And then what sticks out to me is superficially in the dermis, there is some pretty extensive edema. I don't know if you could go all the way to like a vesicle, but definitely edema.
Yeah, I'd probably go to a vesicle. I would agree with you on that.
Okay.
And then we've got,
All right. Got some red blood cells too. And then some spongiosis in the epidermis.
exactly, there's quite a bit of that. And this is an interesting biopsy because it shows a couple of interesting findings here. We'll look at this zone right over here. Okay, so superficial perivascular dermatitis, epidermis is involved, spongiosis. So what's your general sort of category of diagnostic entities when you see this pattern?
Are you asking for a differential or are you asking for more of like a pattern?
Both.
Okay, well, when I went down the like superficial deep pathway, I saw mainly lymphocytes for the inflammatory cells too. One of the things in the pathway is PMLE because of the marked edema. There's spongiosis. You can also have vesicles. Other things, if you went more with like subepidermal vesicular diseases, again, it's lymphocytes. I didn't really find any eosinophils. I don't know.
Here and there, I agree. There's not a gazillion of them. So that would kind of militate against something like a bullous bug bite reaction. There's an EO right there, but you know, it's not like a ton. Like if you saw like somebody that had like a hyperimmune response to an insect bite, you usually would want to see a lot of eosinophils. There are some here, but there's not a ton.
Yeah, so then like pemphigoid and the arthropod, like you said, are kind of out.
Yeah, that would tend to against that. And this is another finding right here. Do you know what this phenomenon is here, where we've got these little gossamer strands of papillary dermis that are sort of like the little ropes that they use to hold down the blimps when they're getting ready to take off, or the, you know, if you've ever been out to the balloon festival in Albuquerque, they've got those ropes that they hold on to those balloons when they're filling up with the hot air, and then they let them go and they go up into the sky. These are little gossamer strands of papillary dermis that are just trying to keep the epidermis from floating away, basically. And they're also probably even have some combination of some, you know, material of the outer portion of the keratinocytes that are mixed into this thing also. We call it reticular degeneration, and it's often seen when you've got either lots of papillodermal edema or you've got massive spongiosis that's formed a blister secondary. So it looks like a subepidermal blister, but it's really not actually a subepidermal blister. It's actually got a combination of the epidermis and then some papillodermal edema there together. So you don't usually see that, for example, in bullous pemphigoid. You know, that's a nice clean split at the DE junction where there's the immunoreactants that get deposited there, or like in EDA or PCT, you don't see that there. So if you see this finding, that tells you that there's probably prominent spongiosis and also some papillodermal edema kind of combination there together, not just really a true subepidermal blister. So it's kind of a clue that's really more in the spongiotic category than in the subepidermal blister category. And a bullous bite could give you that too. You can see it in a bullous bug bite reaction also. So
Okay.
so given that that's what we're seeing here, what is your differential diagnosis? You mentioned what's not so great about polymorphous light eruption. You mentioned that. Um, does that usually give you a lot of epidermal change most of the time?
Not it can have spongiosis, but not most of the time.
Yeah, there's
Um,
some of it that can. There's a so-called papullovesicular variant of PMLE that can do it, and that one's kind of more sort of like juvenile springtime eruption and hydroestivale and that sort of stuff that kind of morphs into that sort of spectrum of photodermatitis. But the classic pattern we see is a superficial and deep infiltrate of lymphocytes that's usually pretty tightly cuffed around the blood vessels with papillodermal edema. And if you get a blister, it's because of just the edema. Usually don't get a lot of epidermal involvement. And if you see people with classic polymorphous light eruption, they really don't have much scale or crust or anything like that going on in their, when you see them clinically, they're kind of edematous plaques or papules, and they don't really have a lot of surface change. So this one, even though it's kind of early on, you can see it's got some crust here. It hasn't really gone all the way to the surface, but this is going to have some abnormality of the, it's going to have some scale on it pretty soon. So probably be a little bit less likely to be PMLE.
okay.
But pretty florid spongiotic dermatitis like this, that's got a blister that's formed secondary to the blowout of the spongiotic microvesicles. What are the classic entities that you tend to think of there?
Well, you could think of eczema, but you would also expect to have eosinophils, which we only had a couple.
When you say eczema, what are you guys being taught that means today? Is that synonymous with atopic dermatitis?
Yeah, well, that's what I take it as. I don't know if I'm being taught that or not, but that's what I say.
Well, a lot of people do. I mean, Dr. Ackerman, my old mentor, used to really rail about that because you say, well, the thing is, it's basically, a lot of diseases give you a reaction pattern where you see spongiosis in it, and atopic dermatitis usually does not give you this much inflammation with this prominent spongiosis like this. If you see somebody that's got really bad atopic dermatitis, they usually have a psoriasiform dermatitis with small amounts of spongiosis and lots of lichen simplex chronicus on it. It's the old, itch that rashes, if you will, as opposed to the rash that itches. And so usually, and that's one of the reasons that I never know when people say eczema, what they really mean. I mean, do they mean sort of a chronic sort of dermatitis with some spongiosis and scale? And they say, well, I'm just going to toss out the word eczema, and maybe they mean chronic contact dermatitis, or they mean, maybe irritant dermatitis. So I kind of agree with him. When people send that in, I don't really know if they really mean atopic dermatitis, which is a little unusual to see that in an older person. Most time we think of that as a younger individual's disease, but a lot of people use it. And I don't really know what they want me to think, because when I see a reaction pattern like this, it kind of throws about 5 or 6 major things into the differential diagnosis. And then atopic dermatitis is one of those, but it's not usually acute spongiotic dermatitis like this. So that would be a less likely diagnosis here. It'd be really unusual to get this much spongiosis with a blister with atopic dermatitis. I mean, have you ever seen atopic dermatitis with vesicles? Almost never.
No.
They get the scale and they get the lichenification and secondary infiltration, but they don't really get vesiculation. So this would be weird for that. What else? What do you think of classically when you think of acute spongiotic dermatitis? What are the 5 diseases, the little mantra that we always talk about?
Well, contact dermatitis.
Yeah, allergic contact. That's probably number 1, that can do that. And when you get this much spongiosis like this, what's probably the number 1 disease that you think about that we'll start seeing in about a month or 2?
The arthropod result?
Well, no, if it's contact dermatitis, what's the number 1 cause of contact allergy that we see coming up in the springtime?
Number 1.
Go out, and the weather's nice. We're going to go out to the woods and start tromping around. We're gonna let our dogs run through.
Oh, like
grab 'em
poison ivy, poison oak.
yeah, roost dermatitis, exactly. And that, when you see poison ivy, this is what it looks like. I mean, it really gives you a florid spongiotic dermatitis when you get a really acute case of poison ivy that requires prednisone and all that kind of stuff. And you biopsy that, that's what it looks like. If you biopsy it really, really early, you may actually see some neutrophils up in the cornified layer like this. I don't know, this may actually be roost dermatitis, I'm not sure, but if you get so-called black dot tinea, black dot roost dermatitis, not black dot, tinea infection, you'll actually see the urushiol pigment in the cornified layer. And it actually is initially is a chemotactin for neutrophils first. And then it turns into the more classic spongiotic dermatitis that we see here. So that's the number one thing that we think about in this case. And if you really get blistering spongiotic dermatitis, you should really think about roost dermatitis. That does it probably more than any. And you can see it sometimes with nickel and cobalt and chromium, some of those kind of things too. But it's more commonly seen, I'd say, with poison ivy. And you don't have to get a lot of EOs, interestingly enough. I mean, a bug bite, you almost always, the vesicular bug bite reaction, you almost always see a lot of EOs there. But you'd be surprised how many times it's really bona fide classic allergic contact dermatitis without a lot of eosinophils in there. And we know that the main type of immunity that causes allergic contact dermatitis is type 4 mediated hypersensitivity. It's not type 1, which gives you the eosinophils. It's more of the type 4. So it's delayed sensitivity. And so this was probably somebody that may have been exposed and then got re-exposed, possibly. I don't know. But anyway, you often don't see a lot of EOs, which is kind of interesting. You sort of think you should, but you don't have to. If you do, great. If you don't, that doesn't rule it out. Same thing, the drug reaction. You don't have to get one eosinophil in a drug reaction. So don't just rest your, hang your hat on you need to see EOs to call this contact dermatitis. But there may be a couple of EOs in here too, but mostly you're right. It's lymphocytes and some histiocytes and maybe a few polys. So what are the other classic spongiotic dermatitis that we think of when we obviously see kind of prominent spongiosis like this?
I don't know that I've learned like a specific set of like five things.
You're getting ready to. So the classic ones to think about are contact nummular dermatitis, dyshydrotic dermatitis, and id reaction. 4, I guess, rather than 5. But okay. Those are the classic ones. Contact nummular, dyshydrotic, id. Those are the ones that really can give you an acute, prominent florid spongiotic dermatitis like this. Nummular, usually less vesiculating spongiotic dermatitis like this, but it's possible to get really a florid nummular dermatitis. And then you can see spongiotic change in lots of other things. Seborrheic dermatitis, we mentioned atopic dermatitis, bullous dermatophyte infection, that can give you spongiotic dermatitis. Spongiosis in bullous pemphigoid, if you get early urticarial stage of pemphigoid, that can give you a spongiotic dermatitis. Erythema multiforme, early spongiosis there too. So it's a reaction pattern that you can see in a lot of things. The classic diseases, the 4 major diseases that give you florid spongiotic dermatitis every time, are contact nummular, dyshydrotic, and id reactions, but you can see it in a lot of other settings. So this was allergic contact dermatitis. I don't know what the cause was here. Just basically, it's just a good example of an acute spongiotic dermatitis with spongiotic microvesicles that have popped, if you will, with these gossamer strands, this reticular alteration here. That's classic for that. So good. Any other questions about that? Everybody got that, presumably? Okay. Why don't we shift gears to something completely different here?
Hi, this is Jamal. I can go for this one.
Okay, great.
So this is like a fairly large nodule or maybe a papule that it looks like maybe either an excision or maybe like a shave of like a pedunculated papule.
Yeah, good. This thing probably was sticking above the surface. You can imagine that. And then they just took a nice shave biopsy of it. Any idea what part of the body he might be on?
It looks like it could be acral.
Yeah,
It looks like
good.
the bottom corneum is pretty large.
Very good. There's nova follicles here. You've got a acanthotic epidermis with some thick cornified layer. So yeah, probably acral skin. Absolutely.
I think it's neoplastic. Most of the cells in there, with all the red blood cells, and it sort of has like these slit-like openings. I was thinking more like a vascular proliferation.
Good. Excellent. Very good. So yeah, if you see what look like sort of slit-like spaces or white spaces at low power, yeah, think vascular. And then you can obviously confirm that when you go to higher magnification. Would you say this is likely to be benign or malignant, or not sure?
Not really sure. Some of the places look a little concerning, but then also others not really.
Okay, good. I think
But
that's
it
a
is
very
ulcerated, but I know some benign things that can be ulcerated too.
yeah, no, that's very good. And given that it's on the sole, or maybe the palm, but it's on an acral site, and maybe it's been chronically traumatized. So if something's on your sole, you're walking on it. If it's this bump that's sticking up, you're going to ulcerate that thing. And then you're going to go to the doctor and say, hey, there's this bump on my foot. It's hurting. And feels like I got a rock in my shoe. And then they take a biopsy of it and then get a diagnosis. So yeah, I think it's vascular also. Hard to tell. They've shaved it, so we can't really use some of their architectural features. I mean, we do see what looks like maybe some kind of a nodular proliferation of something here, maybe another one up here, maybe a third one up there, maybe a different type of morphology over here, which we'll talk about in a second. So when you get something that's kind of multinodular, you might scratch your head and say, well, maybe that is malignant. We're not sure, but we'll go to higher magnification, see if we can see anything else. So we go to higher magnification, and so here, it's sort of hard to appreciate fully here, but we'll go to some of these areas down at the bottom. It's unfortunately not pixelating for us here. Any ideas now as we go to higher magnification here?
I mean, as I get closer, like the vision or the quality's not great right now, but I feel like I didn't really see a whole lot of like mitotic figures, and it didn't seem like a whole lot of atypia to me.
Okay. You don't have to always in this lesion, but you do have these plump endothelial cells here that are associated with this mixed infiltrate where there are plasma cells and a lot of extravasated erythrocytes. Let's see if there's maybe even another area here too. Let's look at all of them. Sometimes when you're looking at these lesions, you kind of have to look at multiple different areas. Here you can see that there's some more kind of a spindly morphology to some of these cells, and there's all this inflammation in the background. And notice how cellular this lesion is. This area here is probably more characteristic right here. So you can see that these are, and this is an interesting lesion because it has two patterns. And in some areas, you've got these cells that are really plump, they're spindle, and they're really forming these almost fascicles. They're closely opposed to one another. And these cells are somewhat irregular with large nuclei, and there might be a mitotic figure or two over here. And then you've got these other areas, like we see, say, over in this one we first looked at here. If you just saw this, what's your diagnosis going to be?
I mean, I thought you could think of like a pyogenic granuloma.
Yeah, exactly. This looks just like in fact, this is a pyogenic granuloma. If you just saw this part of it. But you look at the other area, and this is what's educational about this slide. That's the way this computer is acting. You've got this other area that's you wouldn't call this a pyogenic granuloma at all here, would you?
No.
No, this is a spindle cell neoplasm with these fascicles of these cells here that are pretty atypical now at this power.
Yeah.
You can appreciate that. So how do you put this together?
I mean, I was thinking maybe like a Kaposi sarcoma could sort of look like this, maybe like one of the more densely cellular type, like the nodular.
Yeah, excellent. Kaposi sarcoma. And there's obviously there's several different subtypes of KS, right? There's, so if you think of KS and how it sort of evolves, how does it start off and then how does it kind of end up?
Well,
So,
there's like a patch stage,
sure.
which I wouldn't think of this as the patch stage.
No, you're exactly right. So it starts off as patch, just like mycosis fungoides, patch, plaque, nodular form. Well, here we
Mhm.
do the same thing in KS. It starts off as a patch, which if you biopsy that, it just shows almost just a slight proliferation of these new irregularly formed blood vessels surrounding pre-existing ones, just kind of diffusely in the dermis. Then it goes to a plaque where you just get an increase in the number of those same kind of vascular proliferations. And then it ends up as a nodule or tumor stage where you get it's basically a spindle cell neoplasm where the cells are closely opposed to one another, like you see here in this field. So this would be a nodular stage lesion. So you're exactly right. That's what this is. But how do you explain the pyogenic granuloma-like component at the top?
I wonder if maybe that's area that was traumatized and
Yeah, good. Exactly right. So that's what happens. And this happens all the time in KS, especially when it's in an area that's on like the sole, for example, or sometimes in a mucosal surface where it's been traumatized. You'll see the fasciculated, obvious nodular stage lesion, and then above it where it's ulcerated and traumatized, you'll get this pyogenic granuloma-like granulation tissue morphology. If you don't sample this and you just sample the other part, you're not going to get the diagnosis. So just it's a good teaching point to remember that that you can get traumatized lesions of KS that get pyogenic granuloma-like change at the surface of it. It's not really KS. It's really truly granulation tissue that happens secondary. And, whatever vascular endothelial growth factor is driving this entity or whatever, chances are you traumatize a lesion of KS, it's going to produce more granulation tissue than if just, traumatize your regular skin, because it's probably juiced up and it's sort of programmed to make new blood vessels. So it's very, very common to see pyogenic granuloma-like change at the surface of Kaposi's, especially when it's on an area that's like this near volar skin. So this is a great case, and it's very educational because if you look at the lesion, it shows kind of different features in different areas. So that's good. So if you make this, there's one test you can do if your morphology is not, if you're not a good morphologist, that you can do to kind of help you make the diagnosis. I don't really tend to order the stain myself, but you can order a stain for HHV8, which will be positive in this lesion. And if we did it here, it'd be kind of interesting to see if it was positive both here and in the PG-like area. I don't know that it would be, but that is something you can do if you have a question about the diagnosis. Any other things that entered your mind in the differential diagnosis?
I thought there were a couple of things that sort of looked similar, but not, at least the pictures that I saw weren't great for it, but like the caposiform hemangioendothelioma, maybe angiosarc. And I mean, again, there were parts of it that looked a little bit like a PG, but it wasn't enough pale stroma in the other areas.
Yeah, good. Well, I think caposiform or hemangioendothelioma is generally a very large, deep, widespread, well, widespread over the body, but in a diffuse area where these very irregular, atypical endothelial cells with foci that kind of simulate more kind of a plaque stage lesion of KS. Hemangioendotheliomas, that's probably not in the spectrum of something you need to know about as a dermatologist taking the board examination, but they might throw in bacillary angiomatosis, which can look a lot like the PG-like change that you see up here. I don't think it'd be totally fair to put something like that when you had a pyogenic granuloma-like morphology. Generally, rarely do we see bacillary angiomatosis give you the spindle cell epithelioid component. It can, but that's less common. But angiosarcoma. There is a form that can give you more of an epithelioid morphology that can kind of simulate this pattern a little bit. That usually gives you more of a diffuse, dissecting, irregular staghorn blood vessels in the dermis and not the nodular kind of lesion that you see here. So KS, pretty straightforward when you see something like this. They could ask this on the exam. It's fair. I don't know they'd show you one that's got the PG-like change at the surface, but that's possible. They could ask you Kaposi's on board. So that's something you should make sure you know that. Okay. Another one here. It's a good one. I want to take this one. Nobody wants to take it. Oh, come on. We got to have at least one brave soul in the audience jump on. Did I lose you? Let's see, we got chat. I'm speaking and it's not
Can you
working.
hear me, Dr.
I
Cockerell?
can now. I can now. Yeah, good.
Okay, perfect. So,
It's cutting in and out though.
can you hear me now?
Yeah, that's good now.
Okay, perfect. So sorry about that, Dr. Cockerell. This is Leah from Baylor. I was talking that whole time. Okay, so we have a punch, and from what I'm seeing, our process of interest is in the epidermis. Looks like it's, I would go down the inflammatory pathway.
Good.
From this power, I'm not seeing a lot of epidermal changes yet.
Can you tell anything about the type of cells with this low power?
Yes, I'm seeing some solar elastosis.
You know, there's a little bit of that, but I think you may actually be seeing another phenomenon that actually goes along with this finding a little bit here. Yeah, I think it is there.
Okay, so maybe some mucin.
Well, there's even one other thing that we might be seeing that you're going to learn about here. There might be a little bit of mucin, but I think you may have another phenomenon actually here. What kind of cells are we looking at?
So they look to me like neutrophils, but I feel like I'm also seeing some EOs and maybe some like nuclear dust.
There's definitely some neutrophils, a lot of neutrophils. There's some eosinophils. And then probably what you're seeing here, there may be a little bit of mucin, but anytime you get fairly abundant neutrophils, when it kind of interacts with papillary dermal collagen bundles, more papillary dermal than reticular dermal, you can get kind of a basophilic discoloration of the collagen bundles called basophilia of the collagen.
Oh,
See that it kind of goes along with neutrophils, especially in the papillary dermis. So that sometimes is a clue to the diagnosis. So we do have neutrophils, and where are they located here?
so I'm seeing them at the DE junction, but really also kind of intraepidermally.
Right, or possibly, I think some of that may be in the epidermis, but if we cut a little deeper, it might be like here in this little dermal papilla right there. That's really a
Yes, like a micro abscess type of pattern.
Good. So this is a good pattern because this gives you a limited differential diagnostic list. So it's nice when you get something like this. It's only got about 5 or 6 things that can do this. It doesn't give you, there's not 100 things that can do this. So what diseases do you think about when you see this pattern?
Yes, sir. So I was thinking along the lines of maybe DH or like a linear IgA, bullous dermatosis, potentially like an early BP.
Yeah. Now, so if you're going to put a list down and you're going to favor these items, you're going to put DH first, linear IgA second.
Yes.
How far down would pemphigoid go, given there are all these neutrophils here?
further down. I guess
Yeah.
I just, because of the eosinophils and maybe there's like hint of, is this going to blister? I just thought I'd throw it on the end.
Yeah, and I think that it's possible to get some neutrophils in bullous pemphigoid, but it's much less common. So I would throw that pretty far down. Usually, if you're going to see early stage pemphigoid, it usually gives you a band-like infiltrate of lymphocytes and eosinophils. It can give you some spongiosis. It can give you a little bit of a slight vacuolization of the basal cell layer where it's incipient blister formation. But usually, if you see polys, that would sort of militate against pemphigoid. Now, what other subepidermal blistering disease might give you neutrophils and eosinophils like this, that can look like pemphigoid and has a similar immunofluorescence pattern to bullous pemphigoid?
Like EBA?
Yeah, EBA. So if you're going to get a pemphigoid-like eruption that's got polys, think EBA in that case. So it's more common to get EBA with neutrophils than it is bullous pemphigoid with neutrophils. Okay. Anything else that you put in differential here?
Maybe like a bullous lupus, but kind of less favoring that.
Yeah. With the EOs, I agree. That probably goes down there in the bottom rung with the pemphigoid eye situation. But there might be one other thing that could give you this pattern. If you want to always get the right answer, you can always say drug eruption and syphilis. A drug can do this.
I did not think
theoretically, an unusual urticarial interface drug eruption could do this. I mean, it'd be a funky DH-like drug eruption. So this is dermatitis herpetiformis. So it's a nice example of seeing one of those where you don't have we don't have the immunofluorescence pattern. We just have the nice example here, and you do have some of the little collections of neutrophils at the dermal papillae. When you read the textbooks, they talk about newts primarily, but when you get a lesion of DH that's been around a little bit longer, you can get quite a few eosinophils also. So don't just think that you have to only see neutrophils for it to be DH. You can definitely see some eosinophils. Now, bullous lupus, usually not this many EOs. So I really wouldn't favor bullous LE. But if you think about the classic entities that give you the subepidermal blistering disorders with neutrophils, you think of DH, LIGA, and you think of bullous LE. But bullous LE generally will not have. I've never seen a case of bullous LE with this many eosinophils. So I think it'd be highly, highly unlikely to be that. So that's good.
Dr. Cockerell, could you comment one more time on the blue discoloration now that we
that's
know that
called,
it's DH?
That's called basophilia of the collagen. And it's usually seen more kind of in this area up here. I'm thinking it's possible that this may be some of it down here in this case, but usually you'll see it kind of in the papillary dermal collagen. And all it is just the neutrophil lysosomal granules degranulate, and it kind of interacts with the collagen, gives kind of a basophilic color. And it's really common when you see. It's really seen fairly commonly with dermatitis herpetiformis. So it's kind of a clue. You don't need to see it, but you often see it. And I'm thinking that rather than mucin, given that there are all these neutrophils kind of down in here, that may be what's going on here rather than really mucin, because you don't usually get mucin deposited in DH. Some of it may be solar elastosis also. So I think you're right about that. But some of it may be that basophilia of the collagen that we see as well.
I see. Thank you so much.
You're welcome. Okay. Let's give this one a try here.
Okay, can you hear me?
Hey, thanks.
Okay, so this looks like we're looking at an excision of a neoplasm, and from high power, it looks like it's primarily located at the dermal epidermal junction and some of the superficial papillary dermis. So from high power, this looks relatively well circumscribed, almost kind of wedge-shaped and symmetric. And as we go kind of to higher power, we're seeing kind of these large junctional and dermal melanocytic nests, and a lot of them to me look kind of spindled or epithelioid. And then, So kind of some other things I'm noticing, there's not really much, if any, solar elastosis. So this looks like this could be younger, healthier skin. And
I like that healthier comment. That's good.
yeah. And these look to be primarily melanocytes. It does look like there is some level of atypia. There's a lot of pigment as well. It can be hard to tell in points, but it looks like there might be a small amount of pagetoid scatter as well. So I guess my differential for this lesion would be either like a Spitz nevus versus like an atypical Spitz tumor versus maybe like a spitzoid melanoma.
Okay, so that's the classic differential. And if you just do that, do you think your clinician's going to be happy with you if you kind of give them a differential diagnosis of benign and malignant in the same pathology report?
No, they're probably going to be very unhappy.
They're going to be very super unhappy. Most of them, especially your pediatric dermatology colleagues. What are these?
Those could be Camino bodies.
They sure could be. I mean, you're not going to see them any better than that. I mean, that's just a beautiful, gorgeous example of Camino bodies, dull pink globules in the epidermis. Notice that they're present in multiplicity. There's just tons of them around here. And so, you know, when I see something like this, this to me is a Spitz's nevus. You can make the diagnosis. You don't need to hedge the diagnosis. You don't need to do markers. You don't need to do genetic studies. You don't need to call this atypical Spitz tumor and all that kind of stuff. This is a classic Spitz's nevus, and you can make the diagnosis with certainty and move on to the next case. You don't have to go into a hyper worry state and get concerned and everything else. So this shows all the classic features that you described. It's very well circumscribed. It's very symmetrical. It's relatively small. It's comprised mostly of nests of cells. It's got the abundant Camino bodies. It's got epidermal hyperplasia, hyperkeratosis, hypergranulosis. So this basically shows every single feature of a Spitz's nevus. And when you see something like this, the moral of the story here is that you can make a definitive diagnosis. Now, Spitz's nevi very commonly will give you some pagetoid spread. That's normal. They can give you scattered mitotic figures, and sometimes those mitotic figures can be atypical. That's okay. That doesn't mean that it's malignant. And some people say, well, then let's do the genetics and let's look at what genes are present in this. Well, just because something expresses some genes of malignancy doesn't mean that the lesion is cancerous. A lot of people's normal skin may have some genes of malignancy that it's expressing, as maybe they've had some sunning damage or something to it, but that doesn't mean their entire skin's cancer. So when you see all the constellation of findings like this, you can make a definitive diagnosis. Now, what's interesting is there have been people that have looked at the genetics of Spitz's nevi, and there are about, probably 5 or 6 different sort of genetic subtypes of Spitz's nevi now. There are these alquin fusion type Spitz's nevi. There are these 11p gain and loss chromosomes associated with Spitz's nevi. So there's several different forms of Spitz's nevi histologically. The 11p type tend to give you more of a wart-like appearance clinically, and they tend to give you kind of a spindle cell morphology than the epithelioid types that you see. Like this got a lot of epithelioid cells here in addition to the spindle cells. So just want to make sure that you realize, even though it's sort of like when they used to build the years ago, people would build cathedrals, and as time's gone on and we got concrete and structural steel and things like that, we don't have wood like they have in Notre Dame anymore. They can burn up, but we've kind of lost a lot of the cathedral builders, and so we're sort of losing the morphologists in dermatopathology today. A lot of people now don't feel confident at looking at things and using criteria like microscopic criteria to make definitive diagnoses. So because they don't have that confidence level, they call these things like this atypical Spitz tumor, and they do genetics, and then they say, oh gosh, it might be cancerous and all this kind of stuff. To me, atypical Spitz tumor is not the most common variant that we see of Spitz's nevi. This is the most common variant. We see the classic types far more common then we see these weird ones and whatnot that are called atypical Spitz tumor. So if you're getting back a lot of atypical Spitz tumor and hedging and things like that, you're probably dealing with a cement pourer rather than a cathedral builder. So it's somebody that doesn't feel confident in applying criteria. So just the moral of this story is, if you see this, you can make this diagnosis. And there's the two major sort of places where Spitz's nevi sort of segregate are middle-aged women in their 20s and 30s and 40s in that general category, and children. And so if you see this in a middle-aged individual, that's still a very common site where we see Spitz's nevi. That doesn't mean that they should be all called melanoma because they have Spitzoid morphology. You know, that's really overkill. So I just want to make sure that you realize that there is an entity. It looks like a Spitz's nevus. It looks like this. This has every single criterion for the diagnosis of Spitz's nevus. You really shouldn't have any differential diagnosis when you've got this. Okay, so just the diagnosis is makeable, and it should be made when you've got this kind of morphology. If you have a, you know, maybe a superficial shave or a punch or something, and you got some atypical areas, well, then, you know, it's okay to kind of hedge that, maybe recommend re-excision. But when you've got this, this is, if I were writing a board question, I'd very happily put something like this on there and expect the examinee to choose the right answer or to get the right answer. So it shouldn't, you don't have to hedge everything. So that's good that you got it right. Okay. Now this is a more common scenario where we get like a shave biopsy of something that's more acidic, and then you might lead you to have to kind of hedge something, but here we got something totally different. It's a great case, by the way, and whoever takes this will be pleased with themselves when they get the diagnosis.
I hope I do then. Hey, it's Chelsea from UT. So this was a pretty superficial shave, and it looks like it's a mostly intradermal neoplastic process rather than inflammatory. And it looks like very focalized nodular, either neoplasms, but when I got closer, it kind of looked like maybe there was a deposit, so like a collection of a deposit. So when I looked, I thought I saw some more like foamy cells, so I thought foamy histiocytes.
So then you backed off of the neoplastic category and switched over to inflammatory, right?
So that's part of my question when I get to the end of what I think this is, whether it's technically like a collection of inflammatory cells or a collection of cells making a neoplasm, I guess. I had a question about them.
So what kind of cells do you think these are?
Histiocytes?
Yeah, they are. They're histiocytes. What's this stuff?
So at first, I thought maybe it was mucin or something like gout, but then I looked closer and I thought it was more lipid.
Yes, good. Why lipid?
Well, I think for gout, if it was a deposit, it would be a little bit more feathery.
Yeah, gout's going to give you that. Yes, those crystalline, feathery. Exactly. That's exactly right. So this isn't feathery. This is more kind of amorphous a little bit. I agree with you. And also, you don't see these kind of cells in gout either, do you?
No.
No. Good. So lipid. Why not mucin, however?
So it was a little bit more net-like for this, for the lipids, and I guess it's not blue enough.
You know, the thing that's interesting about this is that this is the exact same tinctorial color and quality that mucin looks like. It looks very similar to this, but this is lipid, and this is extracellular lipid. A clue is if you see these foamy histiocytes here. You don't see that very commonly. Rarely, you see mucophages in like mucocele and those kind of things, but if you get like GA and that sort of stuff, you don't really get the mucin inside the histiocytes. The mucin is actually within the, it's hyaluronic acid that's occurring because of fibroblasts and mast cells, whatnot, are producing it in between the collagen bundles. So this is extracellular lipid, and you don't see the lipid-laden histiocytes in GA and that sort of thing. The only place you might confuse this with might be mucophages in the mucosal. This obviously is in the mucosal. It's not in your mucous membrane. There's no, salivary glands, anything like that. So this is this is a xanthoma-like process.
Mhm.
Good. So that's an inflammatory disease, by the way. So when you get
Okay.
histiocytes, that's considered inflammation. So they're, the histiocytes coming into there, and they're coming in there. The lipids probably deposited first, and the histiocytes are coming in secondarily. I'm thinking here is the way this thing works. So any idea what the diagnosis is here?
Yeah, so I thought it was more of an eruptive xanthoma
Good,
just because from what I understand, when the lipid gets deposited, since it's such a brisk deposit of the lipid, that the histiocytes don't have time to like engulf all the lipids, so that's why
Yeah.
it's extracellular.
That's exactly right. Exactly. This disease happens so rapidly, and these patients will have they're usually diabetics and ketoacidosis, and they'll have their lipid levels are 5,000, and it's usually triglycerides. So this is mostly, and you can tell these little clefts here, these little sort of small areas here. These are little, probably cholesterol clefts and maybe some cholesterol. And then the stuff that looks more like mucin, this kind of feathery, it's not feathery like gout, but it's kind of cloudy, I guess you could say. That's maybe foggy or cloudy like appearance here. This is going to be the triglycerides. It's probably got some cholesterol and some triglycerides in here. And this stuff just comes in and just massively deposits quickly. The histiocytes come in, they try to engulf it, but they can't keep up with it. And then you get all this extracellular lipid that you're seeing here. So this is what you see in an eruptive xanthoma. Now the more chronic tuberous xanthomas and tendinous xanthomas, you don't usually get the extracellular lipid there. There you're usually seeing most all of the lipid is contained within the cytoplasm. And sometimes those histiocytes actually become sort of epithelioid. They kind of look more like this. You just get a solid nodule of these kind of cells without the extracellular lipid. So when you see the extracellular lipid, that really is just basically is almost pathognomonic for an eruptive xanthoma. Now, what's the number one thing in the differential diagnosis here that can fool you?
Granuloma annulare.
Good. That's exactly what I wanted you to see. So sometimes it's important to know where you can make a mistake and what the error is going to be. And it can look very much like GA because it looks like mucin. So that's very good that you thought of that. So this is a nice example of an eruptive xanthoma. If you ever see a patient with eruptive xanthomas, which you will, it's really amazing when you correct their lipid, how fast the skin lesions go away. They actually will disappear within minutes. You sort of think, well, gosh, those are papules, they've been there for a few days or whatever. You can actually watch them go away in front of your eyes. It's really striking when you see that. So these histiocytes do a really good job of mopping up once you get that lipid down, and it kind of shows you the dynamic equilibrium of this lipid and the way that it's kind of going in and out of your bloodstream into the skin. So when you lower that lipid level and you get it down to normal, all this stuff really gets sucked right out of the skin and it goes away really pretty quickly. So that's a nice example of an eruptive xanthoma. So it's good that you were able to get that. All right, it's an easy one, fun one.
I can take this one, Dr. Cockerell. This is Christina. So, looks like we are here on the scalp. This
Yes.
location. We have a lot of these kind of deep-seated hair follicles.
Good.
This is a punch biopsy, multiple sections are on this slide. And it looks like we have kind of our focus of activity is up in kind of the epidermis subcorneal layer, even from this view. In terms of whether this would be inflammatory or neoplastic, I'd say inflammatory with a pattern of like a superficial perivascular dermatitis, potentially. And then
What kind of cells are these here primarily?
I think these are lymphocytes.
Mostly lymphocytes.
Yeah.
There's eosinophils here, but there's not a gazillion of them, are there? No, it's kind of interesting.
Yeah. But then we have this nice, large, foreign body-looking thing in the subcorneal layer that looks to me a lot like this, like the scabies kind of exoskeleton. And then there is a little bit of like looks like a little bit of like hyperkeratosis and like a lot of red blood cells. So like kind of like crusty, like changes, excoriations on top as well.
So what's the diagnosis?
I think this is crusted scabies.
That's exactly right. And yeah, you've got exoskeleton, but you also got a lot of the organelles and things inside the actual gravid mite of the scabies mite right here too. So you see the entire mite here, and look how many there are here. Gosh, there's probably about 7 or 8 just in this one section. Here's like a little residual eggshell here where the scabies mite hatched and moved out. Here's some curly cues up here, which can help you with the diagnosis. Here's some so-called sibilla, which is the fecal material of the scabies mite. So it's kind of got every single thing in here that you can use to make the diagnosis. And why did this patient get this, do you think?
They were probably like immunocompromised or in a bad living situation.
How many mites do you have in your biopsy if we did it? If we biopsy, we might have one if we're lucky to find it at all. You
Right.
probably have a very dense nodular infiltrative lymphocytes with tons of eosinophils here. So this person's probably immunocompromised for some reason or other, and they're not really making a lot of inflammation with a lot of EOs. And notice the part of the body, the scalp. What do you think the clinical diagnosis was here?
Wait, like crusted scabies? Or
What do you think they sent it in as though? Do you think they diagnosed this and sent it in as
no. Maybe like, seb derm or like psoriasis. Something else.
Crusted scabies lesions. A lot of crust up there. It kind of looks like a bad case of psoriasis or tinea, and they've probably been treating it with like steroids or something like that. It hadn't gotten better. They finally take a biopsy, and they were surprised when they got this diagnosis. Believe you me. And I remember myself years ago when we were attending in the AIDS clinic. This goes way back into the 1990s. And I remember there was an internist rotating with us, I think it's second year intern, and we were in the AIDS clinic, and this patient came in with the scaling scalp and everything. And we all thought it was probably just bad seb derm in an AIDS patient. And this internist sort of naively said, well, what about scabies? And we kind of laughed and joked and said, okay, why don't you go do a scraping? And they came back, and lo and behold, scabies. They were
my
right.
goodness.
We were wrong, they were right. So you can get crusted scabies on the scalp, and it can simulate seb derm and psoriasis. So just remember that.
Okay.
And the other thing is that chances are probably people in the office got some scabies too, because when you get mites, scabies, Norwegian, or well, really should we call it Norwegian anymore, I guess, but it's crusted scabies have up to 1 million mites on their body. So they can really have lots and lots of mites. This is a beautiful example of crusted scabies here. It's like an apartment complex filled with these. So good.
Okay.
Or they would probably show you something like this and toss in a few other ectoparasites. So make sure you learn those. Those are pretty much kind of gimmies. Okay, it's a good one because this is a nice contrast to the previous case we just had a couple of slides ago.
Okay, I could do this one. This is Edgar from Baylor.
Great.
So it looks like we have a punch here. There's a lot of hair, deep hair follicles. I'm thinking we're in the scalp as well, or at least in the head and neck area. I would say this is more of a neoplastic process from this level. And I'm seeing what I would call slit-like spaces, poorly formed. So I'm thinking more vascular.
Good. Benign or malignant? Just on the basis.
Given how poorly shaped these vascular and the cells are, I would think more malignant.
Yeah, and whenever you see a neoplasm that's just diffuse, top to bottom, side to side, even though we don't know the differentiation, our instant reaction is going to be, this is going to be malignant. It ain't good. We don't know what it is. And then at low magnification, you can say, wow, there are all these spaces here. So just like with the KS case we had before, we start saying maybe vascular. And so we're going to higher magnification
Mhm.
and see if we can confirm that. And what about now?
So I think I'm lagging a little bit behind, but there we go. I'm starting to see a lot of, I guess, high variation, maybe more atypical cells as well. There's some extravasation of red blood cells too. Um, so I was thinking something down the malignant vascular pathway, something like a angiosarcoma possibly.
Yeah. So nice contrast between this and the Kaposi's lesion we had before. So here we've got these irregular, almost staghorn-like blood vessels. This lesion is so, it's just a horrible, bad, horrible angiosarcoma that's really almost got a so-called epithelioid morphology. If you just saw this
Mhm.
real high magnification, those cells look like they're closely opposed to one another. You might say, gosh, that could even be just a horrible, poorly differentiated squamous cell carcinoma, epithelioid looking like an epithelium. But then you've got
Yeah.
you've got these spaces here. These are the endothelial cells here that are prominently protruding into the lumen. And then some of these are endothelial cells that are floating freely in these spaces here, which is classic for angiosarcoma. So this is an angiosarcoma with epithelioid features. Here are the blood vessels over here. And contrast this with the KS lesion that we had before that was more kind of the nodular fascicles that had the spindle cell morphology, not nearly as atypical as here, where we've got these striking pleomorphic cells with mitoses all over the place, and then these staghorn irregular blood vessels. So one's a malignant neoplasm that's really not starting off as one area and spreading, but it's more kind of a widespread infectious disease caused by HHV8. This one starts off probably because of, UV light or whatever is the trigger that leads to this. And usually these things occur on either after breast cancer surgery on the breast, or they occur of Stewart-Treves, due to stasis or poor flow, or on the scalp is the most common location in an older individual. So this is a bad situation, and it's a good biopsy. Beware of shave biopsies of angiosarcoma. I mean, I've seen the diagnosis missed. If you just get a little superficial shave of something like this, that's not diagnostic. You cannot call that angiosarcoma. I've seen biopsies submitted to us of angiosarcoma this superficial. And you want to get into a lawsuit? Well, do that, because nobody can make a diagnosis of angiosarcoma like this. I mean, you can see there's just 7 or 8 blood vessels there, but that's what the top of an angiosarcoma can look like. You need this kind of thing to make the diagnosis. So if you're worried about angiosarcoma, you need to get out the knife and fork, and you need to take a real chunk biopsy, or if you don't feel comfortable with it, send it to a surgeon. If you feel like, well, gosh, I don't have time to do an incisional biopsy, I'm going to do a large punch like this, send a picture along with it and show us what you're biopsying. That's helpful also. So I've seen the diagnosis of angiosarcoma missed many times over the years, and it's usually not a good story, that it doesn't have a happy ending a lot of times. So just make sure that when you're dealing with a dangerous tumor like an angiosarc or soft tissue neoplasm, you want to take a good, generous biopsy. And if you don't really have the time to do that, we'll then send a picture or make sure there's communication with the dermatologist so that it doesn't get delayed in diagnosis. But it shows you that sometimes you get a lot of blood vessels. Sometimes you just get a solid area like you see here. So nice example of that. Any questions about this one?
Hey, thank you.
Good. Well, it's about time. We have one more slide. Why don't we save that for next time? It's a good case. I want you guys to have a chance to look at it, and we'll talk about it. It brings up a really good differential diagnosis. So we'll kind of go through the next slide in the next session. So thanks again for your attention, and I hope everybody's doing well. We're getting ready to be over Omicron, so maybe we can go back to some live meetings sometime in the near future. You guys have a good day.